So the study we're looking at today is titled Clopidogrel and Aspirin in Acute Ischemic Stroke and High-Risk TIA. It was published in March of 2018, and just as a bit of a background information to catch you guys up, it was a double-blind randomized control trial that compared the rates of ischemic stroke, MI, death from ischemic vascular causes, ischemic or hemorrhagic stroke, between patients taking aspirin alone or in a combination of clopidogrel and aspirin together. So this was tested for the first 3 months after the initial event happened, and the trial also compared the safety of the two regimens with the primary safety outcome being the rate of hemorrhage.
So the population that was tested were patients 18 years of age and older, originating from 10 countries across North America, Europe, Australia, and New Zealand, who had had an acute ischemic stroke or a high-risk TIA. The intervention was the combination of clopidogrel and aspirin, whereas the control was a placebo plus aspirin. The outcome that was studied was the risk of a composite of ischemic stroke, MI, or death from ischemic vascular causes. From a safety perspective, the risk of major hemorrhage was also evaluated. And the results of this study show that patients who received a combination of clopidogrel and aspirin experienced a 5% overall risk of a major ischemic event. But this combination also put patients at an increased risk of a hemorrhage.
Alright, so now we're just going to discuss some of the critical appraisal strengths that we found. So one of the main strengths for this paper in terms of study design was the large sample size. So just under 5,000 patients were enrolled in the study, and it was pretty much split 50-50 for patients put in the control group and patients put in the combination of aspirin and clopidogrel group. A large sample size such as this one will decrease the risk of attrition bias and more accurately reflects the general population and decreases the chance that rare events are missed.
This study was a double-blinded trial, which would decrease both performance and detection bias. The researchers did not know what each patient received, thus they would not treat anybody differently, and the patients didn't know what they were receiving, which decreases the chance that they would over-report.
Yeah, so in terms of randomization, it was very well done. This study used an interactive web-based system to randomize patients in a 1-to-1 ratio, and there were no statistically significant differences in the baseline characteristics at the end.
And in their analysis after the trial was completed, the researchers used an intention to treat analysis, which preserves the randomization that Jill mentioned. Only 6.4% of participants in the combination group and 6.8% in the aspirin-only group were withdrew or lost to follow-up. And this is pretty close to the 5% that states there's still going to be little bias in the trial.
Unfortunately, there were also a few weaknesses for us to consider. So 1.7% of the patients who were assigned to the control group were already taking clopidogrel at their time of presentation. So in some of these patients, it's possible that the previous use of clopidogrel could have had an impact on the trial results.
And while the dose of clopidogrel was kept constant for all the participants, the dose of aspirin varied between each patient, decided by the treating physician. And while we appreciate that each patient received personalized care, we should question if the dose of aspirin had any impact on the risk of hemorrhage.
The study was also stopped early, and this may be considered a weakness. However, the study seemed to be overpowered, as it was stated that the treatment effect had crossed the significance boundary both for efficacy and risk of harm.
So now we're just going to get into some of the current recommendations made in practice today. According to the Calgary Stroke Program, the long-term use of ASA plus clopidogrel is not routinely recommended for secondary prevention of ischemic events in patients with a history of stroke or TIA, but it may be warranted in patients with other compelling indications such as recent MI. But in the Canadian Heart and Stroke Foundation's guidelines for secondary prevention of stroke from 2017, they found that short-term concurrent use of ASA and clopidogrel for up to 21 days did not show an increased risk of bleeding and could be protective following minor stroke or transient ischemic attack.
And in terms of the applicability to patient care, most provinces have a stroke rate of about 800 patients per year, whereas Newfoundland has a rate of 1,200 to 1,400 per year, and it's the third highest cause of death in Canada. Newfoundland has both the highest incidence of stroke and the poorest outcomes. According to the study results, the number needed to treat was 67 for the intervention group, and the number needed to harm was much larger at 200. We decided that this was a well-designed study and the results were valid, so the results should be taken into consideration when treating patients, but it's also very important to focus on individual patients' risk factors. So if a patient is already at higher risk of hemorrhage, don't use the combination therapy. And only use the combination therapy for the first 7 days, because after that, the risk of hemorrhage increases and the benefit also decreases.